It's a real pleasure to welcome one of our own faculty. Dr. Puja Mehta is director of the Women's Translational Cardiovascular Research Program. She's assistant professor and came back to us. She tells me that she actually gave grand rounds here as a resident a number of years ago. So Puja, we welcome you back, and the podium is yours. Thank you.
Hi, good afternoon. Thank you so much for coming on your noon Tuesday to hear me talk about stress cardiomyopathy. So I gave resident grand rounds here in 2005, and I believe Dr. DiFrancesco and Dr. Spell and everybody was here, so it's nice to be back here. So here are my disclosures. I have research support from Gilead and General Electric for clinical trials and studies, but nothing that is supported by them will be presented in this talk today. We'll start off with a CME question. So approximately what percentage of patients with an initial diagnosis of acute coronary syndrome have Takotsubo cardiomyopathy? A, 10 to 20%, B, 5 to 10%, C, 1 to 2%, and D, less than 1%. So why don't we raise our hands for A, B, C, okay, and D? Okay, so answer is C. It's about 1 to 2%, but this is likely an underestimate, but this is what our current thinking is. So over the next 45 minutes, and I want to leave at least 10 minutes for questions. So for the next 45 minutes, I'm going to go into background and prevalence, clinical presentation, precipitating factors, natural history, implicated mechanisms, and then some conclusions. So let's start with the background. So this was Takotsubo, or stress cardiomyopathy, was first described in 1990 in the Japanese literature. So they described Takotsubo-type cardiomyopathy due to multivessel spasm. These are case report. Now, Takotsubo, the word, comes from a Japanese octopus trap, and I'll show you a picture of that. And they said that because the left ventricle takes on that characteristic shape. In the 2000s, you started seeing publications in the Western literature, so Circulation, JACC, American Heart Journal, started publishing reports on Takotsubo. I remember as a resident in 2002, people were talking about a new sort of stress cardiomyopathy that was just starting to be talked about. And in 2006, AHA incorporated it into the classification of cardiomyopathy as a primary acquired cardiomyopathy. So relatively recent naming of the disorder. Of course, it's been here all along, but now we're calling it something. And I think this is important because once you recognize something and you call it something, then people start recognizing it and publishing on it. So this is a picture of a Japanese octopus trap. And if you can imagine, if this is the base of the left ventricle and this is the apex, so see how the apex is ballooned out and rounded, and this is what they saw on their ventriculograms, and that's why they named it Takotsubo. Now it goes by many names: stress cardiomyopathy, broken heart syndrome, apical ballooning syndrome, ampulla cardiomyopathy, transient left ventricular dysfunction syndrome, neurogenic stunned myocardium, and also reverse Takotsubo patterns have been described, as well as inverted Takotsubo. So basically, the opposite, where the apex doesn't balloon out, the apex is hypercontractile, but the base balloons out. So that would be in reverse Takotsubo. Now let's talk about definitions. Currently, right now, there's no well-accepted definition. Mayo Clinic proposed a criteria around 2006, and what they've proposed is transient hypokinesis, akinesis, or dyskinesis of the left ventricular segments, with or without apical involvement, often a stressful trigger, but not always, absence of obstructive CAD, so on angiography, no obstructive coronary disease, new ECG abnormalities, so and modest elevation of cardiac troponin, and then absence of pheochromocytoma or myocarditis, so absence of something else that explains the myopathy. Now I highlight in yellow the absence of CAD because there have been reports of patients who have obstructive CAD who have patterns that look like Takotsubo patterns. So people are still trying to figure out whether to, keep that as a criteria or not. But in majority of the time, people say, okay, if they have obstructive stenosis, we have a reason to explain why they have a wall motion abnormality. And majority of the time, there's no obstructive CAD. In terms of pheochromocytoma, so I'll show you a case series of about 80 cases of patients with pheochromocytoma who have Takotsubo cardiomyopathy. So then it's just pheochromocytoma-induced stress cardiomyopathy. So I don't know if this absence should be included in the criteria. In terms of incidence, it is unknown because it's under-recognized, under-coded, misdiagnosed. And the American Heart Association looked at their hospital discharges in the United States in 2008. This is 732,000 hospital discharges over the year. And the estimate was about 1 to 2% of ACS was Takotsubo. And that's about up to 14,000 or 15,000 cases per year. Another study, so what they did here is they queried hospital records in 2008 from the National Inpatient Sample. So this is about 1,000 hospitals that were sampled, and they looked at ICD-9 429.83. Now, obviously, if you didn't code Takotsubo, then it wasn't going to be included. But 6,837 patients among greater than 33 million hospitalizations. And what you find is that women had higher odds, so 8.8 times more likely to happen in women compared to men, and particularly in postmenopausal women. So women over the age of 55, they're 5 times more likely to have this. So the conclusion was that in terms of hospitalizations, it's about 0.02% of hospitalizations and 1 to 2% of ACS, and it's mostly elderly women. So that's where the focus was and has been. Now, clinical presentation and treatment. So here's our other CME question. I'm supposed to have 3 in here, so here we go. Which of the following is false? So this is a little tricky, so we have to be awake for this one because you're looking for what is false. Takotsubo cardiomyopathy is a benign condition because this myopathy is reversible. How many of you think that's true? Raise your hand. Okay. Takotsubo predominates in postmenopausal women. So this is just me testing if you heard what I said in the previous slide. Coronary microvascular dysfunction is implicated in Takotsubo. So if it's not obstructive CAD, it might be microvascular endothelial dysfunction. And then admission troponin levels cannot help differentiate acute MI from Takotsubo. Okay. So I think we all understand that it is not a benign condition. Now, just a few years ago when I presented this, it was considered a benign condition. So people were saying that, okay, yes, you have a transient LV dysfunction, but its EF drops to 30%, but within 4 weeks or so, it reverses. In majority of the cases, it's benign. Don't worry about it. It's a good thing that you don't have obstructive CAD, and you've got an identifiable stressor. However, more recent data is coming out that actually suggests that their mortality is similar to acute MI at follow-up. So it is not a benign condition. And typical presentation, postmenopausal women, chest pain and dyspnea. So syncope is a little less likely, fatigue a little less likely. This is an acute stressor. And I think I should clarify that, when we talk about, things get mixed up quite a bit in cardiology, because when we talk about stress, everybody says, oh, stress is related to heart disease. A lot of people are referring to psychosocial stressors as chronic stress. So this is acute stress that we're going to focus on in this talk, because acutely, chest pain and dyspnea are the hallmark of this condition, and it mimics acute MI. EKG changes vary. Troponin is positive on admission or later after they get admitted, so it is positive troponin. An echo with LV dysfunction, wall motion abnormalities, usually in the distal LV. Angiogram with no obstructive CAD, and then dysfunction reverses. It can take days to about 3 to 6 months. Now, atypical presentations, in 10 to 30% of cases, there's no evident stressor, no matter how you query the patient, because, we often get, well, you didn't take the right history. Ask them this, and I have experienced this where I've had a patient with Takotsubo, And any stressor that I could think of, I asked them about, and there was nothing that I could really identify. 10% of women are younger, and 5 to 15% of cases are in men. So this is the overall sort of distribution of Takotsubo. And we'll go over the spectrum of EKG patterns. So you can see here in panel A, I hope you can see it, in the anterior leads here, you see ST elevations. So when you have a patient like this with chest pain, dyspnea, with this EKG in the ER, you're not going to know whether this is acute MI or Takotsubo. I mean, you're going to treat them as acute MI. And in pattern B here, you see these deep T-wave inversions, which is also indicates ischemia, ACS. In panel C here, panel C and D is a patient where C was day of admission with Takotsubo and D is day 2. So you can see how the pattern evolves. Here you start, you have the ST elevations, and then on day 2 you get the T-wave inversions and QT prolongation. Which is an important thing to mention is that when patients get admitted, you want to follow their EKG and look for their QT and look at that T-wave, look for those changes, because you may not see something on the admission EKG, but then few hours later, you might see changes. This is interesting where the extent of wall motion abnormalities that you see in Takotsubo, there's a big disconnect with the amount of troponin. So it can kind of fool you because people can come in and their troponin can be, 2.33 mild, and somebody else can have a troponin of 1020, and you would think that, the 1020 may be more severe, but actually the mild troponin leak, if it's Takotsubo associated with severe wall motion abnormalities, then they can present with cardiogenic shock, requiring pressor support, et cetera. So when you look at the pattern, so blue here is the apical ballooning or the Takotsubo patients, and then orange here is STEMI patients. And you can see here that even though their troponin is quite high, Takotsubo patients can have severe wall motion abnormalities. So here's an example of what a typical ventriculogram would look like. And yay, this is playing, so glad about that. So when you look at, so for those of you who are not used to looking at this, so here is the catheter going up the aorta. It's in the aorta here, crossing the aortic valve. It's sitting in the ventricle. And when you inject the dye, you can see here that the base is contracting and the apex is not moving. So this is the classic, typical Takotsubo ventriculogram. Here is an echo. It's a 4-chamber view. So you can see the right ventricle, right atrium, left ventricle, and left atria. And you can see here that the base is coming in, but the apex here is not moving. It's hypokinetic to akinetic. So we're talking about different patterns. So one question is, okay, what are the patterns we need to know about, and are they associated with adverse prognosis? So if you look at the top frames here, these are all end diastole, and bottom is end systole. And you can see here that during systole, so this is the typical one that we just talked about, base hypercontractile, apex hypokinetic, or akinetic. And then here in the mid-ventricular, so you see the ventricle, the mid here is ballooning, but the base is coming in, the apex is coming in. And then this is the basal kind where the base is not coming in, but the apex is contracting. And you know that because if you see how far in the diastole frame, you can see that it should come out all the way here. So these are the different patterns, and I'm showing you this MRI picture because biventricular dysfunction, of course this is pretty bad, but biventricular Takotsubo has also been described. So you see here where the left ventricle is, the left ventricle and the right ventricle are not coming in during systole. So what do we need to know about atypical patterns is that ages are younger in onset by about 20 years. And more frequent ST depressions instead of ST elevations, higher prevalence of neurologic disorders, and we'll go into that, and then less pronounced reduction in left ventricular EF. So those are the atypical patterns. But in-hospital mortality is about the same. So 3.1% for an atypical pattern versus 4.3. No significant difference in this. And I should mention this International Takotsubo Registry. So this is a registry of 26 countries, including United States and a lot of European countries. And they've got this registry, and this is a registry of about 2,000 Takotsubo patients, which has provided a lot of information about the work that I'm going to be presenting here. So that's something to keep in mind. So in contrast to what we initially thought, because that's what I learned, is that it's more postmenopausal women over the age of 55, 60. You want to remember that younger patients do present, and they present with atypical patterns. Now, burden of arrhythmia. So the problem with left ventricular dysfunction is not only that you're hypotensive or cardiogenic shock and you're being treated for ACS, but also it's the arrhythmias. So if you look at ventricular tachycardia, about 2%, and they tend to have malignant arrhythmias because of the prolonged QT as well as the catecholamine storm. So that's something to keep in mind. And therefore, if you have somebody in the ER, for example, troponin is only 3, there are no tele beds. Can they get a non-tele bed? No, they have to be on a tele bed because of this reason. Now let's look at comorbid frequency. So other things that kind of travel with Takotsubo. So this is another systemic review of 1,000 patients. And what's clear is that just like acute MI patients, Takotsubo patients have a lot of comorbid conditions. So obesity, hypertension, dyslipidemia, diabetes, tobacco use, the prevalence is high, and it's similar to ACS or acute MI patients. What's different a little bit is the psychological disorders here. So this is about 24% in this study, but in the registry it was close to 50%. And what the current thought now is that the Takotsubo patients do tend to have more neurologic and more psychiatric disorders compared to your acute MI patients. So and not depression necessarily, but more anxiety. And then other interesting thing here is its malignancies. So this is observational. People have noticed that people who come in with Takotsubo either have a history of cancer or they get diagnosed with cancer later. And for unclear reasons, people are not sure exactly why. One hypothesis is that maybe the paragangliomas or cancers are releasing catecholamine-like substances that are causing stress. Other thing to keep in mind is that there are associations particularly with hyperlipidemia, smoking, alcohol abuse, and anxiety. So I just bring this up so that if somebody comes in with Takotsubo, and let's say that they have no obstructive CAD, don't forget to check their cholesterol levels and follow up on that, because there is an association with just cardiac risk factors. So you want to definitely treat the risk factors. And this is the clinical observational study that I was telling you about. So this comes out of Germany, and if you look here, 0, this is the index when somebody was admitted with a Takotsubo event. If you ask them a history of cancer diagnosis, if you go far back, they had a history of cancer, and then they either get diagnosed later. Now, what about treatment? Unfortunately, I only have one slide on treatment. There's a lot of work that needs to be done in this area. Hopefully now that the registry is starting to actually publish from their work, we'll learn more. But acutely, it's no different than treating ACS because you can't tell the difference. So you're going to use aspirin, heparin, beta blockade if they tolerate it, ACE inhibitors, diuretics if they have an elevated BNP, if they're short of breath, if they're in heart failure, nitrates, and then, of course, if it's cardiogenic shock type presentation, then balloon pump, inotropes, etc. So you're going to treat them as ACS, and once they're stabilized, the question is when they're discharged or when they're seen in clinic, what medications do we leave them on? What's the data? Well, there is no good data. What we have right now is registry data, and this is a little bit of a change. So when I was training, it was thought that, okay, this is a catecholamine storm, so put them on a beta blocker, leave them on a beta blocker. But beta blockers, it's been shown that it doesn't prevent recurrent attacks, and about 39% or so of patients who have recurrent events, they were already on a beta blocker. So it doesn't seem to prevent it. And recently, the registry data is showing that with ACE inhibitors, it's associated with better survival compared to beta blocker. So We don't know. And the ACE inhibitor story, if it's microvascular dysfunction, ACEs help with endothelial dysfunction, so that makes sense. But, often things make sense until you actually study them, and nobody's actually done a randomized controlled trial with a Takotsubo patient and showed improvement in outcome with ACE compared to beta blocker. What do I do currently? I use both. If the patient's able to tolerate it, leave them on it, especially if they have recurrent attacks. Now, stress management, nobody argues with this one because this one everybody can use. But there are no trials that I can show you where they demonstrated that stress management improved recurrent events. Because there are no guidelines, we usually follow ACS, acute MI guidelines, and heart failure guidelines. So let's discuss precipitating factors. Here's your last question. Which of the following have been described as precipitating an event? Serotonin and norepinephrine reuptake inhibitors, such as venlafaxine, car accident, prolonged argument with a family member, or all of the above. So that one is easy. It started getting easier, So all of them have. So emotional stressors. So if we're alive and well, we are at risk for Takotsubo because these are, death of a relative, friend, or pet, interpersonal conflict, job issues, financial issues, such as gambling loss, anger, frustration, panic, fear, anxiety, a diagnosis of malignancy, bad news such as daughter's divorce, spouse leaving for war, legal proceedings, robbery, public speaking. So me right now. And I was just telling Dr. Morris before I started Grand Rounds that there was a study from Harvard back in the 80s, I think, where they looked at catecholamine levels of house staff and a junior faculty member that are giving talks. And they showed that if the baseline's around 100 or so, in the initial period of the talk, it's about 500. And then, as the talk continues, it starts coming down. So, I'm at risk right now. Great. All right, so physical stressors. Post-surgical, so cholecystectomy or hysterectomy. And this is important because, we'll often get called post-anesthesia when somebody's waking up and they're having chest pain, troponin leak, and you want to at least think about Takotsubo. Infection, sepsis, falls, chemotherapy, thyrotoxicosis, seizures, colonoscopy. This is an interesting one here. Look at this, dobutamine stress echo. Can you imagine, ordering a stress test and they're coming in for a stress test and then you precipitated an event in them? That's been described, and then intranasal phenylephrine. So any of these things can kind of precipitate an event. This one I put up not only for pretty pictures, but also because this is an interesting case of a 53-year-old female who was stung by a jellyfish while swimming in the Mediterranean. And the stress of being stung, but also she had to swim really, really fast to get to the shore, so that's a physical stressor. So a combination of the emotional, she was really scared. She describes being, so fright, and then having to physically stress herself. She makes it to shore, but actually is in PEA arrest, gets CPR, and then is transferred to the hospital and diagnosed with Takotsubo, and she survived the event. So combination of emotional and physical stressor. Now, a comment about neurologic and psychiatric disorders. So I put this up to kind of go over subarachnoid hemorrhage, epilepsy, stroke, head injury, anxiety and depression, and all of these things can also precipitate an event. So you can think of it this way. Neurologic reasons, exogenous reasons like cocaine, etc., and then adrenal catechols. So sort of three different sources of catecholamines. And this here is a shout out to Emory, because Emory is this paper here by Larakis and Samuel Owens, and Salim Hayek and others. This is from Emory, and this is the largest subarachnoid hemorrhage and Takotsubo case series published, demonstrating this relationship. Now, Pheochromocytoma-Induced Takotsubo. What's a little bit different about this is it's more the ratio. It's still female predominant, but if you look at the cases, if you think about the general Takotsubo, if it's 90% of cases are women, with pheochromocytoma, it's about 70%, so it's a lower percentage. And then younger age, by about 20 years younger, so, 30s, basically. And then the basal pattern is more prevalent in the pheochromocytoma type. It's about a third. And here you can see here, this is the kidney, and this is the tumor that was excised in this patient with Takotsubo. And then this is the MIBG scan that's used to detect adrenal paraganglioma/tumor, and you can see that there. Now, what about the actual levels of norepinephrine and catecholamines? So this was a landmark paper in 2005 in New England Journal by Dr. Wittenstein that compared people who are having stress cardiomyopathy, compared them to people who are having acute MI going into pulmonary edema. So that's your CLIP class 3 MI. So they have pulmonary edema, and this is normal value. And I took away the standard deviations and made the table big so you guys can actually see the numbers. But basically, if you look at the epinephrine, if this is a normal value, and if this is the average value of somebody having a heart attack going into pulmonary edema, this is the catecholamine level in a stress cardiomyopathy patient. So this is a catecholamine storm, and that is the mechanism. Now, EF in all of these patients, admission EF is in the 20s. It starts improving by week 4. It's starting to recover. And natural history, so Dr. Sharkey, who's done a lot of work in this area from Minnesota, basically showed us in 2010 the natural history of this. And this is about 136 patients. If you look at acute deaths, about 3. Out of the survivors, 17 died. And if you look at the reasons that they died, cancer, infection, COPD, trauma, and then 7, so about 5% or so had recurrence. So abnormal response to catecholamine surge. Over the next 10 minutes, I want to go through the mechanisms. I know it's kind of boring to go through mechanisms, but we'll just do it fast and just bear with me. So the things that are implicated: direct myocyte injury, coronary vasospasm or multivessel spasm, coronary microvascular dysfunction or endothelial dysfunction, neuronal dysfunction or sympathetic hyperactivity. So all of these are a combination of these in an individual. So we'll take each one at a time. So is it spasm? Well, so we saw that the Japanese first published that multivessel spasm precipitated an event. And it makes sense because alpha-1 stimulation, because of the catecholamine surge, and you get intense coronary vasoconstriction. So yes, it makes sense. However, when you bring these patients who have had a Takotsubo event, and if you bring them back and do spasm testing, they don't always demonstrate spasm. Doesn't mean that it rules it out, but it is not always demonstrated. And so multivessel spasm is described, but it is not always seen. And I'm showing you here spasm. So you can see here in the circumflex where this patient at baseline demonstrated this while they were having an event. What is interesting is if you think about women and you think about disorders that are in other vascular beds, so such as Raynaud's and migraines, they tend to be more prevalent in women. And so this study looked at controls, looked at STEMI population, and compared them to people who had Takotsubo. And what they showed is that, yes, people who had Takotsubo were more likely to have Raynaud's, were more likely to have migraines. And so that also makes sense, right, because it's vasospasm. So those are the things that are kind of for this. What is other mechanism is microvascular dysfunction or endothelial dysfunction. And I'm showing you this here. This is one of my favorite slides, and I try to figure out a way to put it in every talk that I give. But basically, when we do an angiogram, we see epicardial, and we miss the whole, the microvasculature. And what is going on with the microvasculature, we never know. So problem here, or if they had chronic microvascular dysfunction, if they had it, and then they were exposed to an acute stressor, perhaps that explains an event. There's not very many studies in this area. There's only one by Amir Lerman's group at Mayo, and what they did is basically looked at their patients who had a history of Takotsubo, brought them back to the cath lab, and did coronary reactivity testing on them, which is a way to test whether their small vessels are working, whether they dilate appropriately like they're supposed to. And what they show is that if this is their reference population up here, what their coronary blood flow would be like, patients with Takotsubo, their coronary blood flow was diminished, so they appeared to have endothelial dysfunction. And if you look at the TIMI frame count, which is another way that we assess for microvascular dysfunction, patients with Takotsubo tend to have a lower TIMI frame count. Basically, it means that the dye trickles down. When you inject the dye, it takes a while for the dye to opacify the entire coronary vessel. So, and the last thing that kind of makes you think about microvascular is that when you look at postmenopausal controls, so women who did not have an event, compare them to MI patients and compare them to Takotsubo patients, which are in white here, and you hook them up to a peripheral tonometry to look at their arterial waveform and then expose them to mental stress, those who had a history of Takotsubo had constriction. If you look at this narrowing, so if you look at if this is your resting during mental stress, you see this diminished or vasoconstriction peripherally. Now, what about direct myocyte injury? So people have looked at endomyocardial biopsy in 5 patients here with the Wettenstein paper from New England Journal. And what he showed is that in 4 patients, interstitial infiltrates with the lymphocytes and macrophages and contraction bands. Now, what's important here is contraction bands, at least what the pathologists tell me, is that it usually is, associated with necrosis. It's a particular type of necrosis that the cardiomyocyte undergoes, and with a lot of calcium because it's a contractile thing, and so you see these thick bands. But what they saw is they saw these contraction bands, but they don't see necrosis. So this is very interesting to me. And then extensive lymphocytic infiltrate in 1 patient. Another paper, this is a basic science paper in rats who were, who had Takotsubo. And what they demonstrate basically is vacuoles, contraction bands. So these are the thick bands that I'm talking about. But then when they recover, you see this beautiful arrangement of the sarcomeres back to normal. So this is so interesting to me. How can you have a complete disarray of your myocyte structure, and then it all kind of comes back? And same thing here. If you look at this in the acute phase, you see the disarray. You see that the connections are, reduced. But then in recovery, it all comes back. Wouldn't it be great to figure out why it does this and use this for all of our dilated cardiomyopathy patients? So why is it that it takes such a big hit and you're, looking like you're in cardiogenic shock or are in cardiogenic shock and then you recover? Now, lastly, pattern of ventricular wall motion abnormalities, because it's not always related to the arterial system, people have said, okay, well, what about sympathetic hyperactivity? What if the vessels are okay, but what if the neuronal system is off? Now, unfortunately, I looked pretty hard, but there is nothing that I could find where the actual human sympathetic system is mapped out. At least nothing in the past 30 years that I could find in papers. But this is the canine sympathetic nerve projections. And I bring this up because what people have shown is that when you block the right stellate ganglion, heart does different things. You get increased heart rates and arrhythmias, but if you block the left, nothing much happens to the heart. So you know that there are differential innervations from the neuronal system. And then you think about the gradient of beta receptors. So let's say that you have a lot of catecholamines. You're in a catecholamine storm, but the actual receptors on the myocardium, if the receptor density is different, then you're going to respond differently. So just to walk you through this, beta 1, typically in the heart, beta 1 to beta 2, 4 to 1. But at the apex, you have a little more beta 2. And the heart does that just because there's more sympathetic at the base and less innervation here at the apex. So just to maintain consistency, it just increases and upregulates the number of receptors here. Now, what may be happening is that when epinephrine binds to beta 2 in physiologic conditions, you get positive, inotropy. It's a good thing. But then when you have too much, it switches to a negative inotropic signaling. So there's like a switch that happens. What goes against this whole structural theory is the fact that patients can have the same person can come in with an apical type and then come back months later with the basal type. So if it's an anatomic problem with that, if it's truly related to that patient's, the way their sympathetics are or the way their receptors are, it's a little bit hard to explain why one time they would have an apical presentation, another time they would come with the basal. So this is still an area of investigation. And one last thing to mention is MIBG imaging. So this is sympathetic nerve imaging, where we can look to see how the innervation is of the heart. MIBG is a nuclear isotope that mimics norepinephrine kinetics. And I've used it at Cedars for research. It's not in clinical use currently, but it is approved for adrenal tumors imaging, right, the MIBG. So when you look at Takotsubo patients, they have MIBG defects. So they do demonstrate sympathetic defects in their myocardium. You can see here that even after 3 months, the Takotsubo patient has less of an uptake of the tracer here at the inferior wall and at the apex. And then what is pro the sympathetic theory is the fact that when you give rats beta blockers, so this is a control. This is when you immobilize a rat and cause stress, their ejection fraction drops. But then when you treat them with an alpha beta blocker, that is attenuated. That drop is back to baseline. All right, so summary key points. Takotsubo mimics acute MI, so treated as acute MI initially, precipitated by emotional or physical stressors. Abnormal response to catecholamines. It's more prevalent in postmenopausal women in general. About 80 to 90% of cases are postmenopausal women. Several patterns are described, and the more abnormalities you have, the worse your prognosis. So don't go by the troponin levels. It's really the wall motion abnormalities and their clinical presentation. And then coronary microvascular dysfunction is implicated, and then remember that it is not as benign as thought. And I want to just, if we have time, and I think we do, we have a few minutes, so I want to just go over 2 cases. These are 2 physicians who I saw at Cedars. So one was a 58-year-old physician with hypertension, hyperlipidemia, who had an unfortunate loss of her 32-year-old son in an accident, presented with ACS. And, she didn't think that she was having a heart attack. So it was like, she didn't know what was wrong, but it was that weak. And she came in and she had EKG changes, was treated as acute MI, but ended up having an echo showing that EF was 35%, and she had classic apical ballooning. And another physician who was 65 with a history of hypothyroidism, reactive airway disease, and anxiety, who was overexerting herself and basically prolonged walking in the heat. So in the summer heat, she was taking a long walk. She had parked far away, and she was tired, but she kept going. She was pushing herself and developed acute shortness of breath and was also found to have Takotsubo. So I will end there and take questions. Thank you.
Thank you very much for that very interesting presentation. A couple of questions from my perspective. One, how do you tell this from Prinzmetal's angina is one question. And a lot of these patients are hypertensive. Is there a associated hypertensive cardiomyopathy in the background?
Okay, so when we think of classic Prinzmetal's angina, you're thinking of diurnal patterns. So usually early morning chest discomfort or middle of the night waking up with shortness of breath. And it's very hard to catch the EKG while they're having an attack because usually they're not with us at the ER, so we can never tell. But if you were lucky enough to catch it on an EKG, you see the ST elevations. So that's the classic Prinzmetal's. In these patients, it's going to be hard to know whether it's Prinzmetal's that precipitated that event. It is possible because it could be epicardial spasm, but they don't typically tend to have recurrent presentations of angina with no other, no troponin leaks or EKG changes. So when I think of when you think of women who have persistent angina, for example, because we see them in clinic all the time, right? Women who are having chest pain, it's kind of atypical, but it's waking them up at night, and then we say, okay, let me put you on a nitrate, and let me put you on a calcium channel blocker. Did you feel better? And yes, they felt better. So that's one way that we kind of say, okay, that's probably spasm. If you brought those patients in and did reactivity testing, you can often demonstrate spasm in the cath lab. these patients with Takotsubo, they don't always demonstrate spasm, and then when when they've finished their event, so let's say their EF normalizes, they have periods when they're asymptomatic. So they're not having, then they're like, yeah, I had this event, it was pretty bad, but now I'm doing great, no recurrent presentations in the ER for just chest pain. So I think that it's a different sort of population. Oh, and then your second question was about hypertension. So yes, catecholamines, obviously, if you have a catecholamine storm, you can have acute rise in afterload and systolic pressure can go up. And people have thought about whether all of this has to do with the left ventricle not being able to pump against that high pressure. So there's some basic science work where they're looking at the aortic stiffness of these patients. So I think that we'll probably have more data in a couple of years on that.
You mentioned there's an association, or there may be an association with infection of Takotsubo. And on the rare cases where we see somebody who comes in with an infection and is in shock, I wonder if you have any thoughts about cardiac treatment. So we know how to treat the infection, but what should we do when somebody has Takotsubo?
Okay, great. So, just to be clear, people have not looked at, there's not a strong association between infections and Takotsubo, but if somebody is coming in with an infection which is considered a stressor for that person, so if they have, sepsis, if they have severe pneumonia and they're intubated in the ICU, and they start becoming hypotensive, you would think, oh, well, they're probably hypotensive because they have an infection. But until you check a troponin and check an echo, and if you demonstrate wall motion abnormalities, it is likely that, you can't rule it out, basically. Then you can say that, yes, this is a stressor for that person. So the infection was a stressor that precipitated the cardiomyopathy. Now, in terms of treatment, you have to treat the underlying stressor for sure. So you're going to treat the infection. But then if they're requiring pressor support, you're going to treat them like if they're in heart failure, you would treat them as they're having heart failure. So, I wouldn't necessarily check catecholamine levels because I think that's where you're going, right? To see if, no? Okay. Well, if they're unstable, then they get a balloon pump. So if they're, if they're in shock, if it's cardiogenic shock, then you treat them as such. So there's no specific difference in terms of treating in an acute setting.
This is working. There's a difference between sepsis with acute decrease in cardiac function. I mean, there's a myocardial depressant factor or a ICU type cardiomyopathy that can take months to resolve. Mm-hmm. Versus, what might be seen as a Takotsubo's type situation, mm-hmm. Just for some who may not know. A number of years ago, I was reviewing as part of an adverse events committee a case of a patient who had gotten a biventricular pacemaker and was doing well, but he and his wife decided to go and select their cemetery plots. And the one with the heart disease walked up the hill to the cemetery plot and dropped dead suddenly. And then the wife turned to go and immediately get help, and as she was coming down the hill, she dropped dead suddenly. I suspect that was a case of Takotsubo's with ventricular tachycardia. Dr. Leon, who was on the phone call at the time, as we were reviewing this, said that was the ultimate case of squatters' rights, that they both collapsed on their cemetery plot. But we do see those instances where the husband will be in the cath lab and the wife develops severe chest pain. It's a very interesting syndrome that occurs. One question is, with this apical ballooning that you see, what is the potential risk of developing a left ventricular thrombus and risk of embolic events, and how do you approach that? Is there endocardial damage that occurs or not necessarily?
Thank you. Thank you for bringing that up. I forgot to add that to my treatment slide, but I meant to, is that because these patients have apical hypokinesis, that apex is at risk of where thrombus can form. And I've actually seen patient where the echo missed a thrombus, and then when we got the MRI, it's there. So often if you see persistent apical deformity, I'll get an MRI to rule out a thrombus. And if the thrombus is there, then I do anticoagulate with Coumadin just because it's acutely there. But that's something to think about and look for. So if the wall motion at the apex doesn't get better, then you want to at least think about a thrombus and look for it on imaging.
And this is just it's a form of reversible cardiomyopathy, when you see somebody who has a very low ejection fraction, it doesn't mean that their life is over. There are other instances such as that with tachycardia-mediated cardiomyopathy, acute myocarditis. We learned that low EFs are really bad, but as Dr. Hirsch used to tell us, if you don't know the exact prognosis, it's better to take an optimistic outlook with the patient and be encouraging rather than focusing on how bad the acute situation is. And I think that's particularly true in Takotsubo's.
Absolutely. Yes. You're welcome. Yeah, I do. I'm not aware of any studies, but it would be a good thing to look at our Emory data and, for patients who we've seen for Takotsubo and just look back to see if they've had an echo within the past week showing hyperdynamic left ventricle, because I'm not aware of anything like that. And there are so many reasons that people can be hyperdynamic, right? Some people, you want them to have elevated heart rates and hyperdynamic while they're, going through their infection I don't always put them on a beta blocker if I see hyperdynamic LV because sometimes they need that. So.
I was just gonna say the problem that we often run into is this notion that this is a diagnosis and the exclusion of coronary disease. And I think you said it really nicely that it doesn't mean you can't have both. Right, so you can have both. The issue is that the coronary disease doesn't explain what you saw on that ventriculogram or echo. And we've had several times where people come in. Probably the most memorable for me was a patient who had a small, an occluded, second obtuse marginal and came in with some subtle EKG changes. You take him to the cath lab and you see Takotsubo plus this, new lesion. And so one question is, did he have both? Mm-hmm. Did he actually have an acute MI and then develop Takotsubo in that context? Certainly makes sense that could happen. But what the reason I raised that is you mentioned with regard to clot the value of an MRI. I just wanted to sort of echo that. And also in the case of patients who have both coronary disease and this presentation, an MRI can be really helpful in distinguishing what the acute presentation is. And I think that's just a helpful thing that it's a tool that may not always be familiar to people, but can be very helpful to sort out kind of what's going on.
Yeah, because you would think that with the Takotsubo, at least from my understanding of the literature so far, is that when they have had a history of Takotsubo, when you do their MRI, the MRI doesn't show scar. Whereas if they had a true MI, there should be scar. So that's the delayed enhancement. That all might change as our MRI techniques get better, and now we'll get better and better at detecting fibrosis, and with T1 mapping and all of that is going to change.
Thank you very much for that excellent.
Thank you.